to remind people that this is being recorded.
Thank you, Meg. I think it's actually, we're starting. Welcome, everybody. This is Anna. Thank you for joining us today at Phase 1 of Heartland's Affordable Care Act Forum. Today we have a lovely presentation by Meg Como, and we'll be starting in another minute. Give some people to join us sometime here.
For those of you who have already signed on, thank you for joining us today, and we're going to ask for your patience for just another couple of minutes while the rest of our group gets on.
So, okay, well, I'll do a brief introduction of Meg. Meg Como, she is currently the co-principal investigator of the Catalyst Center at Boston University School of Public Health, a Maternal and Child Health Bureau-funded National Technical Assistant and Research Center dedicated to providing support to states and stakeholder groups on health coverage and financing policy for children with special health care needs. Meg's policy analysis work has focused on the role of Medicaid in serving children with disabilities, the implications of federal health care reform for children with a broad spectrum of special health care needs, and the causes and consequences of financial hardship among families raising children with special health care needs. In addition to her work leading the Catalyst Center team, Meg serves as the member of the Leadership Circle of the Institute for Professionalism and Ethical Practice at Boston Children's Hospital, and as a faculty member of its program to enhance relational and communication skills. Meg holds a master's degree in healthcare administration from Simmons College in Boston. She has earned several honors, including a Young Investigator Award from the World Federation of Pediatric Intensive Care and Critical Care Societies and the David S. Weiner Award for Outstanding Leadership in Child Health from Boston Children's Hospital. I would like to thank Meg for agreeing to present today, and thank you all for joining us today. And this is Phase 1 of Heartland's Affordable Care Act Forum. So Meg, please, when you're ready, let's begin.
Thanks very much, Anna. I appreciate the introduction. And thanks for inviting me to join you all today. I am looking forward to spending some time with you in the next hour, hour and a half, talking about the Affordable Care Act and its implications for children with genetic disorders. I'm hopeful that I'll be able to share some useful information with you all, and at the end of the presentation, we'll open it up to discussion and questions. I'd like to ask you all to hold your auditory questions. I believe everyone is on mute right now. Until the question and answer period when we'll open up the phone lines for you. If you do have questions as we move along through the presentation, you can use the chat box to type in your questions. If I don't get the opportunity to answer your question within the context of the presentation itself, we'll come back to it during the Q&A period. I can't guarantee that I can answer all of your questions today, but I promise I'll make note of those that I can't answer and get back to everyone with the answers via the Regional Collaborative. I just wanted to say a couple of additional framing words before we get started with the presentation. On the one hand, there isn't a great deal in the Affordable Care Act that directly addresses the needs of individuals with genetic disorders, but on the other hand, there are quite a number of provisions that have the potential to positively impact people with special health care needs, including those with genetic conditions and disorders, and I've been looking forward to sharing those with you today. Next slide, please. For those of you who are not familiar with the Catalyst Center, I wanted to spend just a minute talking about who we are and what we do, because we are your technical assistance resource center around health insurance coverage and financing of care for kids with special health care needs. As Anna mentioned in her introduction, we are funded by the Federal Maternal and Child Health Bureau. We are a project of the Health and Disability Working Group based at the Boston University School of Public Health. Hedwig is a multidisciplinary team, and that includes the Catalyst Center team, representing a variety of relevant specialties when it comes to health insurance coverage and financing of care, including epidemiologists, health policy, value-based purchasing and payment reform, Medicaid and CHIP policy, the experience of families raising children with special health care needs with medical debt and financial hardship, and more. The Federal Maternal and Child Health Bureau funds several topic-specific and diagnosis-specific National Technical Assistance Centers. In addition, the Bureau has 6 core outcome measures focused on the system of services for children with special health care needs, and there's a National Technical Assistance Center dedicated to each of them. We are the center that's dedicated to outcome number 3, working with states and stakeholder groups on achieving the outcome measure that all children and youth with special health care needs have access to adequate health insurance coverage and financing for the care they need. Next slide, please. So that's just a little background on who we are. What exactly is it that we do? We provide technical assistance on health insurance and financing policy to states and to stakeholders, to states in the form of Title V MCH programs, Medicaid programs, CHIP programs, stakeholder groups like the American Academy of Pediatrics, Family Voices, and other child health advocacy organizations, and certainly the regional genetic collaboratives. We conduct policy research to identify and evaluate financing innovations. So we go out into the individual states, and we also look to federal law to try to find innovative practices that help improve health insurance coverage and financing for kids with special health care needs. And then we try to spread news of those innovations to other places so that they can be replicated. We create educational resources like policy briefs and electronic newsletters and webinars such as this one. And we try to connect those who are interested in working together to address complex financing issues. As I'm sure all of you are aware, the healthcare financing environment is one that's very complex. It also tends to be siloed. So individual payers, individual providers, individual families and beneficiaries, individual state agencies, they all have something to do with healthcare coverage and financing. They all have an interest in it. They all have a stake in it. They all play some kind of important role. But opportunities for those folks to all get together and work on the same thing, work on the same issue, the same project, tend to be fairly rare. So one of the things that we do as the Catalyst Center is try to bring folks together from those different stakeholder organizations to try to move the system of health insurance forward for kids with special health care needs. That's where the Catalyst part of the Catalyst Center title comes from. Next slide, please. What can't we do? Well, there are a couple of things we can't do. We don't do direct benefits counseling for individual families. The primary reason for that is because the healthcare coverage and insurance environment tends to be very state-specific. There's a lot of variability between states and what's available and what's not available in terms of insurance. So from our national perspective, it would be incredibly difficult and probably impossible for us to know enough about each individual state to give good, high-quality benefits counseling to individual families. We just couldn't do the job. And there's nothing worse when you're a family member looking for an answer to a problem with insurance when it comes to your child than being given the wrong information. So we definitely don't want to perpetuate that in any way. We also don't do direct advocacy or lobbying. We're 100% federally funded, and we are prohibited from doing that. What we provide is information and education. So we tell stakeholders if they take a certain path, what it could mean in terms of improving financing of care for kids with special health care needs, but we don't tell them what to do. Next slide, please. So who are kids with special health care needs? Kids with genetic conditions are well represented among this population. The Maternal and Child Health Bureau defines children and youth with special health care needs as those who have or who are at increased risk for a chronic physical, developmental, behavioral, or emotional condition, and who also require health and related services of a type or amount beyond that that's required by children generally. So a child has a health problem, and then they also need services in order to address that problem. That makes them a child with special health care needs according to the MCHB. And that's the definition that Catalyst Center tends to use in our work. We look at that broad spectrum of kids. We don't tend to look at specific diagnoses. We tend to look more at the broad spectrum of kids. But children with genetic conditions are well represented among this population. It's difficult to say how many exactly because there are so many different kinds of genetic conditions, and there's no one source that collects data on all of them in the same way. I'm going to use the broad population of children with special health care needs as representative of children with genetic disorders in the next few slides because we do know some important things about them that can be applied to children with genetic conditions in general. The following data on the next few slides is from the National Survey of Children with Special Health Care Needs, and this particular survey iteration was 2009 and 2010. The National Survey of Children with Special Health Care Needs is a survey conducted every 4 years or so with families raising children with special health care needs, and so the data that I'm going to talk about comes directly from parents. Next slide, please. This chart represents the percentage and estimated number of children with special health care needs in each of the Heartland Regional Collaborative states. The high percentage-wise is in Arkansas at 19.8%, and the low is in South Dakota at 12.5%. The U.S. average is 15.1% of the population under age 18 having special health care needs, according to that Maternal and Child Health Bureau definition that we just talked about. So you can see that when we're talking about that broad definition of children with special health care needs, while some people might think that kids are typically healthy, kids are typically developing, they typically don't cost that much in terms of health care services, for this population of kids with special health care needs, it's not an insignificant number that we're talking about. Next slide, please. This chart shows the percent of children with special health care needs in each of the Heartland Regional Collaborative states who did not have insurance coverage at the time their family member was interviewed for the survey. Note that there are 3 states that have asterisks in their little columns. The sample size for each of those states was too small to meet the standards for reliability or precision, so take those with a grain of salt. Now, it can be tempting to look at this chart and make some assumptions about what's going on with regard to children with special health care needs and their health insurance. On the one hand, we can look at this and think to ourselves that, gosh, uninsurance among children with special health care needs is pretty low, even the highest of the high. In terms of the full percentage of kids with special health care needs, it looks like this isn't such a huge problem for children with special health care needs. It can also be tempting to take a look at this chart and make assumptions about which states are doing better than others. But I would caution against that on 2 points. A high-performing system of health insurance for children with special health care needs should show 0% in each state. That's what we're aiming for, not just doing better than our neighbors. We really want every kid to have insurance. Also, we have some idea from this data about how many kids didn't have insurance at the time of the survey, but just having insurance isn't the only criteria that's important to measure and address in health insurance for children with special health care needs, including those with genetic disorders. Next slide, please. Next slide, please, Dustin. Thank you. So children with special health care needs generally have insurance. What's the problem? That last chart showed us that most kids have insurance. Uninsurance tends not to be the big bucket problem for children with special health care needs, including those with genetic disorders. It's underinsurance that's the problem. Underinsurance means having health coverage, but the benefits don't cover what you need, or there's high cost sharing that limits access to care. Next slide, please. So I want to spend just a second talking about the difference between coverage and benefits, because we're going to spend some time talking about those in the next hour or so. Before we get into the details of the ACA, health insurance coverage is insurance against the risk of incurring significant medical expenses. For our purposes today, we're going to concentrate on 2 basic kinds. There are many different kinds of health insurance, but we're going to concentrate today on 2 basic kinds. Private insurance, which includes individual policies that people without access to employer-sponsored insurance buy for themselves and their families, and small and large group employer-sponsored plans. Small and large are defined by the number of employees in the sponsoring company. We're also going to spend some time talking about public benefit programs like Medicaid and CHIP. That's health insurance coverage. Benefits are those services under the health insurance coverage like doctor visits, lab tests, hospitalizations and supplies, prescription drugs, durable medical equipment, those sorts of things that the insurer pays for. Next slide, please. So coverage and benefits that meet the needs of children with special health care needs in general have to not only be present, they also need to be universal and continuous, adequate, and affordable. I'm sure this statement doesn't come as news to anyone, but it's worth thinking about specifically in the context of healthcare reform. Like everyone, children with special healthcare needs, including those with genetic disorders, have always required coverage that's universal and continuous, so everyone has insurance and they can stay on it without interruption. And it's affordable, not just in terms of the premiums, but the cost sharing as well. The co-pays, the deductibles, the co-insurance are manageable in the context of the insured's income and other expenses. And the benefits are adequate to meet the needs of the insured. While the ACA doesn't solve every problem for every person, it is a step in the right direction. Next slide, please. The ACA is actually two federal laws. The first was the Patient Protection and Affordable Care Act, which was signed into law on March 23, 2010. And the second was the Healthcare and Education Reconciliation Act, signed into law about a week later. Together, they're known as the Affordable Care Act, or the ACA. The ACA isn't just the marketplace plans, what some folks call Obamacare. There are multiple provisions in the ACA that impact just about every aspect of the healthcare delivery system in some way. I want to take a minute here to pause to say that I respect that this can be a controversial topic for some folks, and differences of opinion in the ACA are real and valid. But it is the law, and the majority of my remarks will be focused on what's positive in it, what has the potential to be positive, and what can be improved. This reminds me a little bit of my experience with my extended family. My parents are from New York State originally, and all my favorite aunts and uncles and cousins are Yankees fans. My immediate family and my in-laws are all from Boston, and we're all diehard Red Sox fans. You can just guess what that means when we all get together and the game is on. We've agreed over the years to just agree that we all love baseball and watch the game in different rooms, and I'm hoping that that's the approach we can take today. We may have differences of opinion on how to get there, but we all want what's best for kids and families. Next slide, please. As I just mentioned, the ACA is not just the marketplace plans, what some folks call Obamacare. The ACA, as published by the U.S. Government Printing Office, is 906 pages long, and there are actually three major areas of focus in it. There are the insurance reforms, sometimes known as the Patient's Bill of Rights, or the consumer protections, new and expanded pathways to coverage, like the Medicaid expansion and the new state health insurance marketplaces, paired with an individual mandate, which means everyone who can afford it has to have insurance. And there are also cost and quality provisions. Because our time today is limited, I'm going to concentrate my remarks on the first two of these, the insurance reforms and the new and expanded pathways to coverage. Next slide, please. So let's start with some of the ACA insurance reform and consumer protection provisions. These are just some selected examples that have specific relevance to kids with special health care needs and kids with genetic disorders. I'm going to use the term provision a lot in my talk. It means a part of the ACA that provides for a certain thing either being required to be done or prohibited against being done. And it sometimes also includes funding attached to it. It can also be known sometimes as a section along with the relevant number from the final legislation. For example, the first provision in this bulleted list is also known as Section 2701. Starting at the top of the list, and I'm sure many of you are familiar with many of these, the ACA includes a prohibition against denying coverage based on a pre-existing condition. That originally went into effect for kids under the age of 18 back in September of 2010. So it's been in effect for kids for quite some time now, for several years. But as of January 1st, 2014 of this year, it went into effect for adults as well. So now it applies to all ages. Insurance companies can no longer deny coverage to someone based on the fact that they have a pre-existing condition. They also can't decline to renew insurance for a person because they have a pre-existing condition. So for those folks who were afraid to take raises or afraid to change careers or afraid to take different kinds of jobs because they were worried that if they gave up that employer-sponsored coverage that they had, that they wouldn't be able to get new coverage based on a pre-existing condition, that's called job lock. That's no longer an issue. This should be able to give folks more flexibility and more choices around what's best for their families without having to worry about losing their access to health insurance. There's no denial or charging higher premiums based on health status or gender. This is important. In the past, women were often charged higher premiums than men because we use different kinds of health care services. Under the ACA, that's no longer allowed. There are only four ways in which an insurance company can charge an individual a higher premium based on age, if you're older, if you smoke, tobacco use, based on your family size. An insurance company can charge more for a family of 4 versus a family of 2, and geography, depending on where you live. It also allows young adults up to age 26 to stay on their parents' family plan, regardless of whether they're still a student or if they still live at home or if they're married or not. So this is exciting, too, for that population of youth with special health care needs, including genetic disorders, who may have aged out of their parents' employer-sponsored insurance coverage, but who didn't qualify for insurance on their own and who would have become uninsured. They can now stay on their parents' plan until they turn 26. And this is also exciting because in the past, we know from the data that this population of young adults had the highest rate of uninsurance among all folks. There were folks who were just getting their careers off the ground or who were just graduating from school and were figuring out what they were going to do. They didn't have good, robust access to their own employer-sponsored coverage. And for many of them, they didn't qualify for Medicaid because they weren't disabled or they weren't pregnant or they didn't qualify based on categorical eligibility for Medicaid. They had the highest rate of uninsurance among all populations. A recent report by the CDC showed that the rate of uninsurance among young adults has dropped significantly since this provision began. There are millions of kids who now have insurance through their parents' plans who otherwise would have been uninsured. So this is really exciting for that population of folks. For young adults who have aged out of foster care, who had been covered by Medicaid while they were in the foster care system, they can now re-enroll in Medicaid up until the age of 26 as well. Next slide, please. Next slide, please. I just wanted to touch on a couple more. There's guaranteed issue and guaranteed renewal that's effective as of this year. If you qualify for employer-sponsored health insurance, insurer is required to issue you a policy, and they're required to renew it if you remain qualified for it. There's a prohibition under Section 2705 against discrimination based on health status. It explicitly lists genetic information among the health status factors that can't be used in considering eligibility for coverage. There are no annual and lifetime benefit limits anymore. There's no lifetime benefit limit, so you can't put a dollar amount cap on a person's insurance coverage. You can't put an annual benefit cap on their insurance coverage. You can't put a dollar amount on there. Now, I would note that this is important. The benefits themselves can still be capped, so the number of visits or the number of services can still be capped. The dollar amount associated with them, however, cannot be capped. So we no longer have situations in which infants are discharged from the NICU having already reached their lifetime maximum benefit cap and who are effectively, they may still be on insurance, but they have no more benefits left, so they're effectively uninsured. We don't have that situation anymore, which is really good for kids with special health care needs and their families. We do continue, however, to have a concern about benefits themselves being limited, making sure that folks who need chronic care services like rehabilitative and habilitative services are able to continue to receive those. So that's an issue that we're continuing to watch under the ACA to see if it's changed for better or not. Next slide, please. So I spoke about this just a second ago, guaranteed issue and guaranteed renewal, and a prohibition against discrimination, which is important. Genetic information, again, is listed as one of the specific health status factors that cannot be used against folks anymore in terms of health insurance coverage. Next slide. Another provision of the ACA requires that preventative services be covered without cost sharing. Now, there's a small caveat associated with this. It's not a small caveat, it's an important one. This preventative services provision only applies to in-network providers. So if you are going for a healthcare service that's a preventative service, and you know that it should be covered without a copay or coinsurance or deductible being charged, it's important to make sure that the provider offering that service is within your insurance company's network. The insurance company is not required to pay for services outside of the network. This does apply, though, to all kinds of different insurance, which is really good. It applies to all new non-grandfathered group health plans, both fully insured and self-funded, or so-called ERISA plans, and new individual policies issued or renewed on or after August 1st, 2012. I just mentioned grandfathered plans, and I wanted to take just a second to define that for you, because I think for some folks that's a new term. A grandfathered plan is an insurance plan that was in effect as of the signing of the ACA in March of 2010, and that hasn't changed significantly since. So the insurance company hasn't either raised their premiums substantially or reduced benefits significantly. Over time, grandfathered plans will eventually phase out as insurers have to make adjustments to premiums and/or benefits to keep up with costs. But they're important for us to know about now, as grandfathered plans are exempt under several ACA provisions. And I'll make note of those as we go along. Next slide, please. So you may be wondering what exactly is covered under the preventative services provision. It includes the preventative services under the recommendations of the United States Preventative Services Task Force, the A and B recommendations. And there's not enough room on the slides for the list of all of these services, so I provided you with a link to the list themselves on the following few slides. If you cut and paste these web links into your browser, then you can go directly to the list themselves. But I'm sure many of you are familiar with these. The recommendations of the Advisory Committee on Immunization Practices adopted by the CDC is also included. Next slide, please. The preventative services in this provision generally apply to screening, but I would note that the HRSA guidelines released by HHS in August of 2011 incorporate by reference relevant provisions in an Institute of Medicine report that was also released in 2011. In some instances, the IOM committee report provides additional interpretation of the Preventative Services Task Force recommendations that we just talked about. For the Preventative Services Task Force BRCA recommendation, the IOM committee interpreted the recommendation to include referral to genetic counseling as well as the testing if a clinician decides it's appropriate. So genetic counseling and BRCA testing, if medically necessary and appropriate, have to be made available as a preventative service without cost sharing under this ACA provision. I'd also like to note the Bright Futures recommendations for pediatric care are included under this provision. So that's important to both children with special health care needs, but also adolescents. Next slide, please. As I just mentioned, the preventative services provision generally applies just to screening, and that's true for the rest. There's no guarantee that treatment will be covered for babies who are confirmed to have a genetic condition. But under the preventative services provision, the rest screenings must be covered in private insurance, those different kinds of private insurance that I just described, without cost sharing for the family. Next slide, please. Another important consumer protection provision under the ACA requires insurers in the individual and group markets to provide a standardized uniform coverage summary, no more than 4 pages long, so that folks who are purchasing insurance can actually see what they're getting before they sign up for a particular insurance product, and so that they can use it more effectively afterwards. This is a screenshot from a publication by the Kaiser Family Foundation on the Uniform Coverage Summary, showing an example of what it should look like. And you can see there's a web link on the bottom to the full brief about the Uniform Coverage Summary from the Kaiser Family Foundation. You can go actually by cutting and pasting this into your browser and see the full brief with more information about this. This makes folks who are purchasing insurance, who have special health care needs, who have to make sure that particular things are covered or that particular benefits are covered, it makes it easier for them to make those comparisons between insurance products and really know what they're getting before they put in a claim and it gets rejected. Next slide, please. You may have heard of the navigators and the consumer assisters who are available under the ACA to help people choose and sign up for coverage. In addition to using healthcare.gov, I know, but it is getting better. I tried it myself, and it is getting better. You can also contact, by the way, your state's insurance marketplace directly to locate the navigators and consumer assisters that are available in your state. I would note here a very important resource, though, for this specific population with regard to benefits counseling, as well as peer mentoring support for families, are the family-to-family health information centers. There's one in every state in the District of Columbia. The F2Fs are funded by the Federal Maternal and Child Health Bureau, and most importantly, they're staffed by trained, experienced family members who understand how the many systems important to children with special health care needs, like insurance but also education, work in their individual states because they use them themselves. You can find the F2Fs through the National Center for Family Professional Partnership website or on the Family Resources page of the Catalyst Center website. I have those addresses for you at the end of the presentation for you to be able to, again, cut and paste into your browser if you're interested in looking at the web links themselves. Next slide, please. The ACA requires insurers in both the individual and group markets to establish an independent appeals process for coverage determination and claims issues. Now, grandfathered plans, as I mentioned earlier, are exempt from this provision. But for non-grandfathered plans, which are becoming more and more prevalent, this provision applies. When a claim is denied, insurers have to tell enrollees now the reason the claim was denied, that they have a right to file an internal appeal, they have the right to request an independent external review if the internal appeal was unsuccessful, and that there is the availability of the consumer assistance or ombudsman's programs so that folks can get outside help in navigating the insurance maze. Next slide, please. For more information on the rules regarding appealing private health insurance decisions, you can go to this web link. This is from HHS, and it'll describe in more detail the particular provision that I've been referencing. If you think an insurance company is out of compliance with these rules, the best approach is oftentimes to contact your state's insurance regulator. This web link on the second bullet here goes to the National Association of Insurance Commissioners. There's a nice little graphic. There's a map of the United States. You just click on your state, and it'll bring you to the contact information for your state's insurance regulator. And you can ask them directly, is this allowed, is this not allowed? Next slide, please. Because state-mandated benefit laws are so important to the genetics community, I wanted to pause here for a moment and address them in the context of the ACA. The ACA has some relevance to state-mandated benefit laws, but before we get into that, I want to talk just a little bit about state-mandated benefit laws in general. They require some private insurers to pay for specific health services. So examples of interest to our community include coverage of medical foods and formulas, for example, newborn screening, those kinds of things. Self-funded plans, also known as ERISA plans, have always been exempt from state-mandated benefits, and they continue to be under the ACA. The ACA doesn't change any existing state-mandated benefit law. There is an intersection between existing state laws and the health insurance marketplaces in the individual states. I'm going to talk about that in a little bit more detail to come, but the ACA didn't take anything away when it comes to state-mandated benefits. If you have a state-mandated benefit law in your state, it continues to stand. Next slide, please. There are other laws that impact people with genetic disorders that have relevance to the ACA. For example, GINA, the Genetic Information Non-Discrimination Act of 2008. GINA and the ACA are different in some important ways. GINA was a civil rights statute. It prevents discrimination in both health insurance coverage and employment based on an individual's genetic information, and it includes strong privacy protections. The ACA was created for a different reason. It's comprehensive healthcare legislation. Its primary goals are to expand health insurance coverage to uninsured folks and increase consumer protections in the private insurance market. Provisions in the ACA prevent discrimination based on diagnosed disease as well as health information. While GINA and the ACA are different, they are complementary to one another. The Congressional Research Service did an analysis back when the ACA was first passed and found that while there's some overlap and some minor differences between GINA and the ACA, there's nothing outright contradictory. Payers have to comply with both laws. Next slide, please. So we've been talking up until this point about the consumer protections of the ACA. Let's turn our attention now to some of the primary strategies that are aimed at reducing uninsurance and getting folks onto health insurance coverage, and also, in some ways, trying to improve their benefits. In addition to the many existing pathways to coverage, like what may be available through your job, there's one new pathway to coverage under the ACA, the state health insurance marketplaces, also known as the exchanges. I'm going to call these the state health insurance marketplaces because they are individual to the states. But in some states, the state runs the exchange themselves, the marketplace themselves. In some states, the federal government runs the marketplace. And in some states, there's a partnership between the state and the feds in running the marketplace. But because they are state-specific and their variability between them, I'm going to refer to them as the state health insurance marketplaces. There are also two major expanded pathways to coverage, Medicaid and the Children's Health Insurance Program. Eligibility for coverage under all of these different kinds of insurance are based on a variety of different factors, most importantly income, but also access to other coverage and state policy choices. Benefits vary depending on the source of the coverage, so it's important to know if your question is something covered, is something not covered, it's important to know what the coverage is to begin with because the benefits differ between them. Next slide, please. So let's start by thinking about the state health insurance marketplaces. Open enrollment is closed for this year in the marketplace unless you have a qualifying family event. A qualifying family event is something changes in your family that makes it appropriate for you to pick up health insurance or change the health insurance that you have. Some examples of qualifying events are if a person is born into your family, you have a new family member, or a person is adopted into your family, you have a new family member. That's a qualifying family event. If a person in your family passes away, or if you get divorced, those are qualifying family events. So if you think you have a qualifying family event, contact the state marketplace if you think you're eligible for that kind of coverage, and see if you can't get in. Don't automatically assume that if you've had a qualifying event that you have to wait until the next open enrollment period. The next open enrollment period for coverage starting in 2015 will start on November the 15th of this year and go until February 15th of 2015. I think it's important to note that the enrollment period is starting later and it's ending earlier than this previous year, so that's important. There's a narrower window for open enrollment this coming year than there had been previously. So if this is something that's important to you, those are important dates to be aware of. It's always open enrollment for Medicaid and CHIP, by the way. You can always apply for Medicaid and CHIP. There is no open enrollment period for either of those two public benefit programs. The state health insurance marketplaces offer a choice of individual policies and small group plans. These are also known as the Qualified Health Plans, or QHPs. There's help for consumers in choosing a plan. There's a comparison website. There are navigators. There are assisters. There are also tax credits and subsidies available for enrollees with income between 100% and 400% of the federal poverty level. I think sometimes people look at the federal poverty level and they have no idea what the context of that is. Let me give you an example. For a family of 400% of the federal poverty level is about $93,000. Next slide, please. So we're looking at a program that's available for middle-income people as well as for low-income people. Eligibility for marketplace coverage is for individuals and employees of small businesses. And there are different levels of plans that are available with different cost-sharing obligations. Some folks call these the heavy metal plans. They start with what's called a bronze plan, going all the way up to a platinum plan. The bronze plan on the lower end of the scale covers 60% of eligible health costs, and the insured pays 40%. Whereas on the opposite end of the scale, the platinum plan covers 90% of eligible health care costs, and the insured pays 10%. Obviously, the premiums are different for these two kinds of plans and for the ones in between. You're going to pay less in premiums for a bronze plan, but you're going to pay more in cost sharing. For a platinum plan, you're going to pay more in premiums, but less in cost sharing. So folks who have special health care needs, who have disabilities, who have chronic illnesses, who know that they're going to use more health coverage, who know that they're going to use more health services than a typical person might, it's important for them to have a sense of what they think they might be using and weigh and measure, not just look at the premium cost, the upfront cost, but also balance that with the cost sharing over the period of the year. Next slide, please. So I wanted to spend just a second talking about minimum essential coverage, which is also known as MEC coverage. MEC coverage includes employer-sponsored insurance, large group insurance, Medicaid, CHIP, a variety of different kinds of insurance outside of the exchanges that is available to folks before the ACA and continuing to be available to them afterwards. The individual mandate under the ACA requires that everybody who can afford health insurance have it unless they get an exemption. The IRS has defined what qualifies as minimum essential coverage, or MEC. Having MEC coverage means you're all set with regard to the individual mandate. However, individuals with access to what's called MEC coverage are not eligible for premium tax credits and subsidies in the marketplace. They can still sign up for it. It's still available to them. They can still sign up for coverage under the marketplace. They're just not eligible for those premium tax credits and subsidies. This is an important consideration for families of children with special health care needs who have dual coverage. So they have private insurance for their family as their primary, with Medicaid playing the role as supplemental or wraparound coverage for the child with a disability as an individual. Let me give you an example of this. Take this little cartoon family. We'll call them the Smiley family. The whole Smiley family has private health insurance through Mrs. Smiley's job. That's MEC coverage. So they're all set for the individual mandate, and they all have their private health insurance coverage. But little Sam Smiley here, as part of the family, has a disability, and he's also enrolled in Medicaid, which covers his copays and his deductibles and the things that he needs that are medically necessary but that aren't covered by Mrs. Smiley's insurance. If the Smiley family enrolls in marketplace coverage, their premiums will be calculated on a family of 4, but if they're eligible for tax credits or subsidies, if they make between 100 and 400% of the federal poverty level, those tax credits and subsidies will be calculated for a family of 3. If the Smiley family's income is over 400% of the federal poverty level, by the way, they wouldn't be eligible for subsidies anyway, so this point would be moot for them. Each individual family in this situation who has a child with a disability who has dual private and Medicaid coverage is going to have to decide the best option for them, but they're not prohibited from eligibility in the marketplace if that's a better deal for them. I think this is one place where the family-to-family health information centers, who are very well versed in this, can be helpful, as well as the consumer assisters and the navigators. Trying to figure this out on your own can be quite complex. Next slide, please. Let's talk for a little while about the essential health benefits, which are Section 1302 of the ACA. The ACA requires that individual and small group plans include essential health benefits, including those that are offered through the marketplace. So we talked a little while ago about the different kinds of insurance. There's private insurance, and then there's public insurance. In the private insurance, we talked about small group plans and individual plans. So the essential health benefits apply to those two kinds of private insurance, whether they're sold within the marketplace or not. Plans covering large groups, grandfathered plans, and self-funded or ERISA plans are all exempt from the essential health benefits. So this is an incredibly important provision for individual and small group plans, but they don't apply to large group plans, grandfathered plans, or self-funded plans. So it's important to realize that there's a divide between the different kinds of insurance that we're talking about and exemptions associated with them. For folks, however, who are eligible for individual and small group plans and who sign up for it, the essential health benefits have the potential for addressing underinsurance. Next slide, please. Under the ACA, the requirement for the essential health benefits included that the scope of benefits have to reflect those covered by a typical employer plan. The HBs have to take into account the health needs of diverse population groups, and people with disabilities and children were specifically called out as populations that needed to be considered. It includes benefit categories under 10 broad service categories, and those benefits have to be balanced among the 10 categories. Next slide, please. This is the list of the 10 broad service categories that was included under the ACA. This list comes directly from the ACA, but you can see that it doesn't include a lot of detail on the exact amount, duration, or scope of the benefits to be covered under each broad category. There's one qualifier to that statement. You'll note that preventative and wellness services are listed, and they have to be covered in the same way that we've just discussed under the preventative services provision with no cost sharing. So other than that one piece where there was an intersection between the essential health benefits and another provision in the ACA, when the ACA was first passed, we all had the sense that these were broad service categories. They looked very generous. They looked very robust, but we didn't really know where the rubber was going to meet the road. We didn't really know what the details were going to be about whether something was going to be covered or not covered, how much it was going to be covered, how it was going to be defined. Next slide, please. The ACA, as passed, directed the Secretary of Health and Human Services to determine the scope, duration, and definition of benefits under those 10 broad service categories. After a lot of careful thought and a lot of thinking about historical precedents, in particular the way that CHIP benefits were designed, instead of one standard benefit package for all of the state marketplaces and individual and small group plans, HHS authorized states to choose one of 4 different kinds of current plans to use as a model or a benchmark. This is called the benchmark approach. Next slide, please. So those choices were all made last year in preparation for the opening of the state health insurance exchange marketplaces. So the benchmark plans have all been chosen by the individual states. Because each state's essential health benefits were built using different benchmark plans, there's no standard answer as to whether a particular service is or is not covered under an essential health benefit. However, the Center for Consumer Information and Insurance Oversight, which is run by CMS, has put together a convenient website so that you can easily access your state's benchmark details. If you go to the web address at the bottom of this slide, cut and paste it into your browser, and then scroll down the page, you will find, next slide please, this list of the states. And they have links to in-depth information on the benchmark plan for each individual state. So all you do is just scroll down, find the state that you're interested in. I used Maryland in the following examples because it just happened to be where my cursor clicked. Next slide, please. And this is what you'll see. It starts with a summary of the benchmark plan. The first section is summary information. What kind of plan was chosen, who the issuer was, the plan name. You'll remember that in that list of broad service categories, pediatric services, including oral and vision care, were included. In many existing benchmark plans, pediatric oral care, dental care, and vision care wasn't already a part of the benchmark plan. So states had to say on this summary, they had to report to CMS how they supplemented that coverage, what they chose in order to make sure that those services were included in their benchmark. They had to say whether habilitative services were included in the benchmark plan, and if they weren't, how they were defined. You can see that here as an example from Maryland. Next slide, please. Then if you scroll down on that same page, you'll find the specific benefits and the limits associated with them. Here is where you'll find out whether the specific services that are important to children with special health care needs, including those with genetic disorders, are included or not in your state essential health benefits. In Maryland, for example, the lists include lab work, x-rays, CTs, MRIs, and PET scans, prescribed medical foods for people with metabolic disorders, generic, preferred, and non-preferred prescription brand drugs, as well as specialty drugs. So this is a good place. If your question is this covered, is this not covered, this is a good resource to be able to go and look and see in general in your state if something was or was not included in the essential health benefits. Next slide, please. I said earlier that it was important to think about state-mandated benefits, existing state-mandated benefits in the context of ACA and how they didn't necessarily change under the ACA, but that they did have relevance with regard to the essential health benefits. I'm going to go into a little bit more detail on that now. I promised I'd go back to it, so here we go. The ACA, as written, said that states had to cover the cost of state-mandated benefits that go beyond the essential health benefits. But because the ACA didn't include the details of the essential health benefits, just the broad service categories, this caused some consternation among states who had already been experiencing serious economic pressures. You'll remember that the ACA was passed at or close to the height of the economic recession. So states were really worried about, and continue to remain really worried about, additional unanticipated costs. Subsequent rules have clarified that the state-mandated benefits that were in place as of December 2011 are automatically considered essential health benefits. So states don't have to worry about whether they go beyond the HBs or not beyond the HBs and whether they're on the hook for the cost associated with them. They're automatically included. This only applies to mandated benefits that impact care, treatment, and services, not provider type, for example. Any limits that were in the original state-mandated benefit law continue to apply. So if there were exemptions in the original state-mandated benefit law based on type of insurer or application to specific kinds of diagnoses, those continue to stand as well. Next slide, please. So you may be wondering, how can I figure out what kind of state-mandated benefits my state has? It happens that on the same website that you'll find the benchmark plan, you'll also find under that same list of states, you can click specifically on the state-required benefits. State-required benefits is just another word for state-mandated benefits. Again, this is Maryland, and you can see here there's a list of what the benefit is, the name of the required benefit, which kinds of plans the law applies to, and then the actual citation number for the law. So with a lot of these, there are caveats and details and sort of exemptions here and there. Some of them are big, some of them are more subtle. To really understand whether something is included under a state-mandated benefit or law or not, I really strongly suggest cutting and pasting into your browser the citation number and actually going to the law and reading it. This is just sort of an overview summary that will give you an idea, but to really know the details, go to the citation number, read it, and it'll give you a lot more sense of whether something is covered, whether it's not covered, and if there are limitations associated with it. Next slide, please. So we've been talking up until this point about expanded pathways to coverage and new pathways to coverage. Let's think for a little bit now specifically about Medicaid. You may recall that the Supreme Court a couple of years ago was asked to rule on the constitutionality of the ACA, and specifically they were asked about the individual mandate. Is it constitutional for Congress to require people to buy something? The court looked at the ACA and ruled on several different questions. The one that's applicable here is around the individual mandate. The court ruled that the individual mandate is a tax, and Congress has the power to levy taxes. So yes, indeed, they do have the ability to be able to require folks to buy something. The law itself is constitutional, and its provisions will go into effect as scheduled. But there was one exception. Next slide, please. And that was the Medicaid expansion. You may recall the ACA, as originally passed, required states, all states, to allow non-disabled, non-pregnant adults ages 19 to 64 to enroll in Medicaid. This was a new eligible population. It also raised the income level for every population, existing categorically eligible folks as well as the new population, to 138% of the federal poverty level. The Supreme Court said that the penalty to states for not complying with that requirement was coercive. the penalty under the ACA was the loss of all federal funding for a state's entire Medicaid program. If you think about the context of carrots and sticks, that's a really big stick. And the Supreme Court said it's too big a stick. It's coercive. States really don't have a choice. They would have to do it. And so the Medicaid expansion was ruled an exemption under the ACA. The expansion is still allowed, but as a state option, not a requirement. So states are going through a process now where they're choosing whether or not they're going to expand Medicaid to this new population of eligible folks who, in the overwhelming majority of states prior to the ACA, were not eligible for Medicaid at all. They were not pregnant, not raising children, not children themselves under the age of 19, and not disabled. They didn't qualify for Medicaid. So this is an important piece to think about in the context of the ACA and your individual state. For states that don't take up this expansion, uninsurance among non-disabled, non-pregnant adults is predicted to continue to be a problem. And my concern is, in part, Medicaid has a pretty specific definition of disabled, and they don't think about folks with special health care needs. They think about people with functional limitations. They think about people with disabilities. So you can have a person who has some pretty significant health needs based on a genetic disorder who doesn't qualify as disabled in terms of Medicaid coverage, but who doesn't necessarily have access to employer-sponsored coverage or the right kind of employer-sponsored coverage to meet their needs. So for states that are not expanding Medicaid, the population of folks in this category, the uninsurance is predicted to continue to be a problem there, and I think that that's an important thing for us all to be watching. I would just like to make one more comment about the Medicaid expansion. HHS and CMS have not put a time limit on a decision around the Medicaid expansion. So I mentioned earlier that states had to make their benchmark choices by a certain date because they had to be ready for the state insurance marketplaces to open. A state can decide at any time whether it's going to go forward with the Medicaid expansion or not. The clock is not ticking right now for that particular state decision. So I think that this is an important thing for us all to keep an eye on as time evolves, as things evolve, to see what happens. Next slide, please. So I can't resist this point because I think it's an important one. We've been discussing the Medicaid expansion for adults. The Supreme Court's ruling applies only to the new mandatory population of adults, those folks who were non-pregnant, non-disabled between 19 and 64. Children are an existing Medicaid eligible population, and so this exemption, this state option around the expansion doesn't apply to them. Children's income eligibility, family income eligibility has increased to 138% of the federal poverty level in all states based on the ACA. Sometimes folks wonder when they hear that the floor for Medicaid income eligibility for kids is going up to 138% of the federal poverty level, they think to themselves, well, gosh, you know, in my state we've always covered kids well above that. Is the ceiling going to change? If the floor is going up, is the ceiling going to come down? And that's not true. For states that have income eligibility levels for children higher than 138% of the federal poverty level, they're actually not allowed to change their income eligibility levels until at least 2019 under a provision in the ACA called maintenance of effort. Maintenance of effort requires state Medicaid programs to keep the eligibility criteria that they had in place when the ACA was passed back in 2010 until 2019. And they're not also allowed to introduce any new administrative burdens to make it harder for people to sign up their kids for Medicaid or to renew their kids' Medicaid coverage. States are allowed to make changes, though, to make it easier. They are allowed to make changes to increase their income eligibility if they want to, but they can't make it harder and they can't lower their income eligibility. Another provision under the ACA with impact around public benefit programs is kids who are currently enrolled in separate CHIP programs, the Children's Health Insurance Program, whose family income is below 138% of the federal poverty level, they're going to move to Medicaid. And that's actually a good thing because there is no to very, very low cost sharing in Medicaid. There's also a child health benefit package in Medicaid called EPSDT, Early Periodic Screening, Diagnosis, and Treatment. That applies to kids under the age of 21. So there are better benefits in Medicaid compared to CHIP or private insurance, which is good for kids. And there's also no to very low cost sharing in Medicaid. So it's going to save families who are making that move some money, and it's also going to get their kids access to more medically necessary benefits and services. Next slide, please. With regard to Medicaid benefits, traditional enrollees, folks who are eligible for Medicaid based on the rules that have always been in place in a state outside of the ACA, will continue to receive benefits under the state plan. For the newly enrolled population of Medicaid folks whose states have decided to expand Medicaid, they are going to qualify for something called the alternative benefit plans. They include benchmark benefits, including the essential health benefits that we talked about under the marketplaces and the individual and small group plans, and that preventative services provision with no cost sharing. For kids under the age of 21, they're going to continue to get early periodic screening, diagnosis, and treatment, which I just described. For those children who had aged out of foster care, up until age 21, they're going to re-enroll. If they re-enroll in Medicaid, they're eligible for EPSDT. And then after that, they're eligible for the traditional state plan benefits up to age 26. This population is exempt from mandatory enrollment in the alternative benefit plans. Next slide, please. So I've been talking a lot about laws and legislation, statute, and details and caveats and all of that up until this point. And your head might be spinning just a little bit. Some folks like to read background materials themselves before jumping into health insurance decision-making, or in helping others jump into health insurance decision-making. There are a lot of excellent materials out there right now. There are a lot of really terrific groups that have been doing some really good work around providing consumer navigation and assistance around making the right choices for folks. I think one of the things that we've been thinking about and concerned about at the Catalyst Center is making sure that kids and families not only get into coverage, but get into the right coverage for their needs. There are a lot of folks out there who have similar concerns and who are doing really terrific work. One of the primary sources that we like, though, for benefits counseling, in addition to the Family Health Information Centers, comes from the American Academy of Pediatrics. If you go to the web link on this screen, healthychildren.org, and then go to the health insurance pages, you'll find short articles on a variety of health insurance topics that have been specifically written for parents, not policy wonks like me, but for moms and dads and family members who are making decisions around choosing health insurance for their children, especially those with special health care needs. There's one called the Affordable Care Act, What Your Family Needs to Know. There's one called Reviewing Your Family's Health Insurance, the questions to ask. It doesn't tell you what to choose, what not to choose. It tells you what you should be thinking about in making the right choice for your individual family. There's one about exclusions and limitations, how to read the fine print when it comes to those uniform coverage summaries, how to really get a sense of what you're buying, and understanding cost sharing, deductibles and copays and coinsurance. So we think that these benefits counseling materials can be really, really helpful to providers in sharing with families, for family members to read themselves in order to make good decisions for their families, for consumer assisters and navigators in helping families make the right choice for themselves. Next slide, please. Here are a few other resources that we like. And again, this is not an exhaustive list. These are just sort of the high points, the highlights. There are other folks out there doing lots of good work, and I don't want to give the impression that because I didn't include them in this list that they aren't doing good work. But for the time that we have and the space that we have, I did want to sort of offer you the greatest hits. I promised that I'd share the State Family to Family Health Information Center's web link. That's here first on the first bullet point. Again, they're staffed by trained and experienced family members of children with special health care needs themselves. So they not only can provide really good quality information about how to use a system because they use it themselves, but they can also offer that kind of peer mentoring and connection that can be so important to families when they're working their way through not only navigating health insurance, but health care. It's a complicated system. The education system's complicated. Social services, complicated system. The community-based support's complicated system. Those family-to-family health information center folks, because they sit in a sort of family family perspective themselves, they see how all of those different systems interact with or don't interact with one another, and they can really be helpful in navigating these multiple different mazes that families are faced with. The Catalyst Center has some really good resources. This is the shameless plug portion of our presentation. We have a list of resources that are specific to health insurance, but also to the ACA, a list of publications specific to the Affordable Care Act, an extensive array of policy briefs and white papers, archived webinars, other resources to help you learn more about the ACA and other strategies for improving health insurance coverage and financing of care for kids with special health care needs, including those with genetic conditions. The Kaiser Family Foundation has they have a wide array of resources available, but two major ones that I use quite frequently. One is state data, very specific around the ACA and state data, and another around healthcare reform more in general. And you can find these two web links on this chart. Next slide, please. The National Coordinating Center for the Regional Genetic Services Collaboratives at the American College of Medical Genetics also has some resources available to you. There's an ACA implementation work group. If you're interested in joining that, I would suggest contacting Alicia Keene at the NCC and asking her about that. The ACA implementation work group is working on 3 major projects right now, in addition to all the other things that they do. Project number 1 is identifying best clinical service practices for 3 representative genetic diagnoses. They include sickle cell, Fragile X, and PKU. We chose those based on the fact that they can be representative of other kinds of genetic disorders. So we're creating a template in which, for each of those 3 individual diagnoses, what are sort of the best clinical practices? What kinds of services are needed by folks with those diagnoses? If you were to have a sort of model care plan, what would it look like? Project number 2 is going to take the information from the model care plan and determine what in it is currently being covered in Medicaid and the marketplace plans and what potentially is being left out. So we're going to try to get a sense of good high-quality care for folks with these specific diagnoses. Where's the ACA working for them? Where is it maybe not working for them? And then project number 3 is an analysis of those strengths and gaps and sort of trying to figure out what all of it means and where things could be improved potentially for patients and families and providers in the future. So if you're interested in that work, I would suggest getting in touch with Alicia. Next slide, please. So what can I do? Getting involved is the first step. Getting informed is an important first step as well. So you can sign up for Catalyst Center coverage, which is our e-newsletter. There's a product and activity announcement list that goes out periodically to folks when we produce a new webinar, when we produce a new policy brief, when we come out with a new white paper. You'll get automatic notification of that by email. We also have 2 e-newsletters. One is called Catalyst Center Quarterly. That includes original analysis of Affordable Care Act related information and technical assistance opportunities. We also compile media highlights, big news stories that have relevance to health insurance coverage and kids with special health care needs from around the country. And we include those in a curated list of resources called Catalyst Center Coverage. And that would come to you automatically as well on a bi-weekly basis. If you read our policy briefs and participate in our webinars and ask us technical assistance questions, that's a really important way to stay both informed yourself, but it also really helps us. We don't know from a strategic planning standpoint where our efforts can really make the biggest difference unless we hear from folks in the field about what they need. So you're asking us technical assistance questions helps us understand what the concerns are in the field from families and providers and folks on the ground so that we can best address our efforts and our energy and our time and our resources in ways that can be helpful to you. You partner with other advocacy and consumer groups, lending your voice and expertise to theirs. You can comment on federal regulations when they come out. There are oftentimes federal regulations come out in the Federal Register with pieces to them where your experience can be enormously helpful in sharpening and shaping it so that it meets the needs of folks with genetic conditions. And it's really only by having that voice represented that the folks who are writing these can understand what the needs are of the population and craft ways in which to help them through regulation. So your comments and your voice and your expertise are incredibly important in those areas, and they are most welcome. Next slide, please. So in summary, the ACA offers some historic opportunities for improving health insurance for kids with special health care needs. For instance, through improved access to universal and continuous and affordable coverage, be the consumer protections and the new expanded pathways to coverage, and those benefit provisions that we discussed, like the essential health benefits. Whether these opportunities turn into real progress remains to be seen, but we are going to be tracking it with our family leader and professional provider partners to see what's happening on the ground for kids with special health care needs and their families, and we'll keep you informed. Long-term sustainability of state and federal funding is a significant concern. Simple coverage isn't enough, and whether it's going to be meaningful to folks who use the health insurance sort of remains to be seen, so we'll also be keeping an eye on that. Because the ACA doesn't do everything for everyone, the need continues to work on improving health insurance coverage and benefits. So the ACA is a really good start, but it's not the be-all and end-all. It doesn't do everything for everyone, and there are still opportunities that we're going to need to be aware of and leverage and take advantage of in terms of improving health insurance coverage and financing for all kids with special health care needs, including those with genetic disorders. Next slide, please. Applying maternal and child health expertise in the following areas is going to be vital in helping to realize the promise of the ACA. So monitoring and enforcement, keeping an eye on what's happening and reporting it to the folks who are responsible for enforcement is really important. Outreach and enrollment, making sure that folks have the information they need to make good choices for their families. Gap-filling services, including enabling services, are going to continue to be an important role that maternal and child health folks need to continue to play in terms of the context of the ACA, but also outside of it. Facilitating collaborative partnerships between family leaders and Medicaid, CHIP, and the marketplaces, bringing that consumer voice into the folks who are making decisions and making policy is incredibly important, and MCH professionals and family advocates can be the bridge, the conduit to that. Familiarity with and access to CSHCN data, like the National Survey of Children with Special Health Care Needs, which we started the hour talking about. Public health perspective, being able to talk about the importance of prevention and the importance of wellness, especially for people with chronic illnesses, chronic health care needs, special health care needs, and disabilities. I think sometimes that gets lost in all of the other specialty care. But it is incredibly important in terms of if we're going to improve the quality of people's lives, the quality of their health, and also control costs further down the line. Being able to bring that public health perspective to policymakers and decision makers, I think, is an important role that we can all play. Thinking about the life course, not just today, not just tomorrow, not just this year's budget, but thinking about the life course for people with genetic conditions, I think, is an incredible fundamental piece that we can offer as well. And our knowledge and experience with quality improvement measures can be incredibly important as well. Next slide, please. So I want to pause here, apologize for going on and on and on and on and on and not letting anyone get a word in edgewise, but that's the way we set things up today. Now it's your turn to ask some questions or spark some discussion. I want to open things up now, and thank you in advance for your time and for your attention. I've enjoyed our time together so far, and I'm hoping that I'll be able to answer as many of your questions as possible. Did we receive any questions in the chat box?
Thank you, Meg, for a very informative presentation. Dustin, do we have any?
None that I've seen.
This is Lori, and I have one. I was going to type it, but I can unmute myself. So, Meg, yes, thank you so much. This was excellent, as usual. I wanted to just clarify around BRCA testing. The languages that what's covered is the genetic counseling process, not the genetic testing. Is that correct?
Oh, thank you. Thank you. That's an important clarification. Any other questions?
If anyone has any questions, would you please raise your hand and I'll go ahead and unmute you.
I do see one question in the chat box, and it looks like, I'm not sure if it was answered about, will this webinar be recorded and made available? I do believe it was recorded.
Yes, I recorded it and it will be posted to the website.
Thanks, Dustin.
Well, if anybody doesn't have any questions, I would like to say thank you, Meg. It was very informative.
Anna, before we move on, Dustin, would you mind just changing to the next slide? Great. This is my contact information. If folks think of questions later or if they just want to address them privately, please feel free to give me a call or contact me through the Catalyst Center website. I'd be happy to talk with you further.
Thank you, Meg. The webinar will be available within the next 48 hours. And I also would like to make a quick announcement. Phase 2 of the Heartland ACA Forum will be an in-person meeting in Kansas City, Missouri on May 22nd. Heartland will cover travel-related expenses for all attendees within the Heartland region. I will be sending an email with the registration link and a draft agenda. And for now, we'll probably have the registration deadline on May 19th. So thank you, everybody, for joining us today. And I hope I get to see you in Kansas City on the 22nd. Thank you, Meg.
Thank you all. Take care.